And the Managing Two Worlds Together project is the third stage of a three-stage project, I was going to say. So it's the last bit of a project. And essentially it says, it observes that healthcare is delivered in specialised segments and mostly succeeds or fails as a package. So you might have bits and pieces operating well, but in terms of the package, the continuum, that may not be the case. So tracking patients' experiences through the system is an effective way to evaluate how and why the package works or doesn't. The project investigated what works well and what needs improvement in the health system for Aboriginal and Torres Strait Islander people. And Judith can go into a little bit more detail around that. It highlighted the critical segments and gaps and produced practical tools that can be used by many families, patients, health professionals, etc. And at the launch of this project in Adelaide, Pat and I were at, when was that, Judith? A little while ago. Middle of the year. It's all a bit of a blur, but there was this story that was told about the continuum, the patient journey, and how we kind of, over-invest in the specialists, the surgeon. So if someone has to get from the APY lands to Adelaide for surgery, and we kind of, sort of almost bow down to these highly specialised professionals. But in terms of looking at the map, the surgeon has about that much play. So we've got to get real about where all of the things can go wrong for that patient and the family, or right, to get the optimal outcome. So it's a bit of a rewiring and a rethinking, and we've developed some tools around that. But I'm probably stealing your thunder, Judith. So Judith Dwyer works at Flinders.
Thanks, Romley. Is it working? Look, I'd also like to acknowledge the traditional owners and thank Auntie Matilda for her welcome, and also for speaking to me, because I am one of those white academics. And I want to say one thing about that and about working with the Lowitja Institute, and that is that what the Institute has given me as a non-Aboriginal researcher is a proper authorising environment in which I can know that what I'm doing is at least relevant to the knowledge needs of Aboriginal organisations and communities, and at best might be helpful. So I'm going to talk about the Managing Two Worlds Together project, and the problem we were funded initially by the South Australian Health Department to look at what goes wrong and what might work better in the care for rural and remote Aboriginal patients who needed to come to Adelaide City hospitals for healthcare. And we knew that Aboriginal patients, country Aboriginal patients in particular, are missing out. They get their care later. There are missing patients. You know from the data that there should be more people coming for things and they're not there. They presumably have given up on getting care, and there's hardship for the patients. And whenever care goes wrong, there's a lot of waste for everybody. So that was the problem that we set out to look at in this project. So these patient journeys that rural and remote Aboriginal people go through, they're the most complicated patient journeys you could ever wish for, really. And we knew from the beginning that we needed to focus on the whole care journey for the patients. As Romley said, the healthcare succeeds or fails as a whole package. We also knew there were so many sort of factors swirling around that impact on how that care works and what it's like for the patients. We knew that we had to develop some frameworks for understanding and analysing the many kinds of issues that affect the journeys, including the broad social factors, the health system factors, and also the full dimensions of health, of what health means for the patients. And there's an important distinction that needs to be made here. We weren't under the illusion that healthcare providers can address all of those things. but what is important is that they be aware of them and take them into account, because if they don't, it will affect negatively the care journeys and make the care that the providers deliver less effective. So that was sort of the first thing that we realised, that there was a lot going on and we needed to have an organised way of analysing it. The second thing we got to was what we ended up calling the complexity principle. You know, hospitals and health services are set up to deal with clinical complexity, and they've got systems and protocols in place for doing that. So what we came to suggest was that they also need to be responsive to patient journey complexity. Not every Aboriginal patient from the bush is going to need a tailored response to their patient care journey, but it is predictable that many people will. And if that reality is ignored and not prepared for, then it's costly in every sense for everybody. In the hospital clinical units that we worked with on this project, we realised that there were two kinds of responses that hospitals and wards were making. The first was to have a built-in response, that is, to predict that there's going to be complexity and to have the responses ready. And just to give you an example of that, there's a very good burns unit for children in Adelaide, and they had designated a member of the clinical team as the coordinator. And whenever they got word that a child with a burn was coming down to Adelaide, that coordinator was on the phone to the primary care providers and the Royal Flying Doctor Service and whoever else was involved in looking after that patient, so that they could get as much information as they could before that patient arrived about their home situation, their family situation, who was able to come with them, and of course all the clinical information that they needed. So that was an example of a built-in response to complexity. The other kind of response, which also happens, is the reactive one, where the hospital just keeps running the business as usual systems and they react to the problems that occur after they happen. So we used the frameworks of all the factors and the insights that we'd had about dealing with complexity to develop patient journey mapping tools. Okay, now I'm going to tell you a story about one of the patient journeys that was mapped. This is complex healthcare, so it's a complicated story. Sit back and relax. So, this is a story about an Aboriginal woman who lived near Port Augusta in rural South Australia, and she had renal failure and diabetes. She became, really unwell and was transferred to the Royal Adelaide Hospital, where she stayed for 10 days. She was, and her condition was stabilised and her meds were changed and so on. There was a plan for her to be discharged on a Saturday to go to an Aboriginal step-down facility, one of Joy's hostels, that had some daytime, weekday healthcare support. So she was going to stay there for the weekend and then be sorted out and travel to Port Augusta on the following Monday. But then something changed in the hospital, and it was decided to discharge her on the Friday afternoon to the hostel for her to have dialysis on the Saturday morning and then travel by bus to Port Augusta later on the Saturday. This was already a complex discharge which had been planned in detail for the Saturday, and there were, further diagnostic tests and so on and drugs that needed to be got together. So they all had to be scrambled in order for her to be able to leave on the Friday. And she eventually arrived at the hostel at about 7:30 p.m. and was picked up at 7 a.m. the following morning to be taken for the dialysis session before she travelled. She was dropped at the bus stop at noon, but the bus had just left. So she waited 4 hours for the next bus and then had a 5-hour bus journey. She had no phone and her family had no phone, and they didn't know that she was coming home early. The city hospital staff didn't really know how long the journey would take, and apparently no one had thought about whether she had water, food or money for the journey. Okay, it sounds like a disaster about to happen, but it turned out it wasn't disastrous. It was tough, but it wasn't disastrous. The City Hospital had rung the Port Augusta dialysis unit, where this woman was a regular patient, on the Saturday morning and asked if they could give the woman a taxi voucher when she arrived in Port Augusta to get home. But that clinic was only open on Saturday mornings in Port Augusta. So the team discussed what they were going to do because it was too late to stop all this happening. One of the nurses drove in her own car on her own time to meet the 4 p.m. bus, and the woman wasn't on it because she'd missed it. And that nurse then went back at 9 p.m. For the next bus, and she picked her up and drove her to her home outside Port Augusta. So there are many questions about what went wrong in that patient journey, and particularly in the discharge. Why was the woman discharged early, before the planned time? Why wasn't she given a taxi voucher at the Royal Adelaide? Why wasn't the Port Augusta dialysis unit more involved in the new discharge plan? So the nurse who picked her up was able to make sure that she was still stable and get her home in good shape. The team then decided to use this case to test the patient journey mapping tools. And both the Port Augusta staff and the Royal Adelaide Hospital staff worked together to document and organise this, really complicated story. They figured out several important changes that could be made in future situations based on that story. Just to give you a feel for this, one of the important ones is the difference between being discharged home and having care transferred. So when you're discharged, you're on your own. I mean, you are in charge of your own life. The hospital has to let you go at some time. They discharge you, that's it, you're on your own. If, on the other hand, your care is transferred to another healthcare provider, then different arrangements apply. The transport tends to be better organised, and the person is not let go until the receiving unit knows all about it, has all the information, and agrees that they can accept that transfer. So that was one of the big realisations that those renal staff had. They realised that they needed to organise these discharges on the basis of being transfers. You might be sitting there thinking, none of this is rocket science. It all sounds like common sense. And it is, but it is system science because, as I hope you can tell from the story, the healthcare system is set up to work in certain ways, and if your story doesn't fit into that way, then you could be in real trouble. Friday night discharges are notorious. There wouldn't be a GP in the country that doesn't complain about Friday night discharges. But they continue because that knowledge loop isn't closed. And that's what the patient journey mapping, in that interactive way, involving the staff who needed to know about it, that's the difference that the patient journey mapping can make. So just to finish off, mapping patient journeys in a structured way makes these complex patient journeys visible for the first time really to everyone who's involved in the patient's care. It identifies all the players and the gaps in the services, and it enables staff to develop solutions together. And it also provides evidence for broader system changes that might be needed even though the staff can't by themselves make those changes. These tools are now being used in practice settings, in education and in quality improvement activities in most states around Australia. Thank you.
Thanks, Judith.